great to be here today. And when Richard talked to me about coming and talking a little bit, I think that obviously we have a room full of people who know so much more than I do about the fundamentals of nutrition and dietetics. And there is no need for me to belabor a lot of statistics that you already know and that frankly probably a lot of you in this room helped to craft. And a lot of the knowledge that you helped create about the importance of nutrition in public health. I wanted to talk a little bit more about the evolution of thinking at the federal level and at HHS in particular about population health, about social determinants of health, and the role that nutrition plays and should play, and we hope in the future will play more in how to achieve better population health in the U.S. Of course, at HHS, we are incredibly blessed to be able to work with some of the greatest healthcare researchers in the world, people who are truly setting the standard for understanding about public health and population health on the planet. And those are the people at CDC, NIH, and the FDA. Truly the source of incredible, valuable, and critical knowledge that helps us make better public policy decisions about public health. And really where a lot of that knowledge has driven us and where Secretary Azar and our leadership team have really begun to embrace is looking at healthcare is knowing that we have to base our policy decisions on data. What we do has to be data driven. But at the same time, what that unlocks for us is the ability to develop policies that are outcome based. Because there's a lot of people you hear, we don't have a health system in the US, we have a sickness system. And we base so much of healthcare on individual episodes and encounters of care. And that data allows us to look at the 30,000 foot level of health in the US and be able to design policies to create better outcomes across the board, better outcomes for individuals, better outcomes for communities, and better outcomes for groups within our population, because absolutely, there are clear disparities in healthcare in our country and in health in our country. And you cannot develop responsible or humane healthcare policies if you don't acknowledge and factor into your policy-making decisions the existence of those disparities. And that is something that at HHS and in Secretary Azar's policy objectives, integrating that awareness and that understanding into our policy making is a critical component. And then when we talk about trying to improve population health across the board in the US, and when you look at outcomes, you obviously have to look at the entire continuum of care. So you need to be looking at things that we're doing actively, enhancing access to behavioral health care, looking at areas of care that traditionally have not had a seat at the table. Now, as most of you know, the CDC, the FDA, NIH, HHS itself has always taken nutrition and health and dietetics very, very seriously in terms of their impact on health, in terms of their impact on individual health and outcomes and population health. But there is a real commitment that it needs to have a more prominent role because of its critical impact on population outcomes. And because when you look at it from a cost effectiveness standpoint, it is a cost effective investment in public policy, because we can have such a positive impact on health outcomes and population health simply by paying more attention to preventing diseases rather than sinking more and more money into the ongoing treatment of chronic diseases. And the awareness that nutrition is a critical element of that is not lost on any of the leadership at HHS today. And here in the Midwest, in Region 5, the area that I represent the secretary in, obesity is a significant problem. It is one of the regions that has one of the highest rates of obesity in the country. In our region, we're running about a third, between 30 and 33% obesity rate among adults in Region 5. And I don't often, tip my hat to the people of Minnesota because, I'm a big Bears and Hawks fan, so I can't always root for folks in Minnesota. But their obesity rate in Minnesota is considerably lower. You get further down here into Illinois, Indiana in particular, very high obesity rates. So it's something that is particularly a particularly acute issue here in the Midwest. Now, when you look at, traditionally, I know a lot of you have probably had a lot of interface with HHS and HHS programs, either in the entities that you work with who may be funded or may partner with HHS, one of our operating divisions here, but there has traditionally been, and there currently is, a great deal of work going on at HHS that I want to touch on. But I think also one of the most important messages that I want to leave you with is to amplify the drumbeat. The time is now, and elements of healthcare and public health, like nutrition, there is really a tremendous opportunity to enhance the profile of nutrition as a critical tool in population health. And it's also a critical tool when it comes to addressing healthcare disparities in this country. So the opportunity is here, and what I can commit to you is that I and my colleagues at HHS understand that, and we are very, very enthusiastic about partnering with stakeholders like yourselves to enhance and amplify that message when it comes to policy making here in the U.S. And I was talking with Jay just a little bit ago. I had been the regional director here in Region 5 from 2005 to 2007, and I was asked to come back, and I thought maybe this time I can get it right. We'll see. Jury's still out on that. But a lot of people frequently ask me, what's the big difference between when you were at HHS 12 years ago and today? And I will tell you, it is the mindset of the leadership. And a lot of the people who are at HHS, Secretary Azar, Deputy Secretary Eric Hargan, a fellow Chicagoan and Illinoisan, a lot of the senior leadership at HHS are back from previous tenures at HHS, which is actually a great thing because you have people who understand the department, understand the mechanics of it, and really have a good working knowledge of what we can achieve at the department. But folks have asked, what's the big difference between your first term and now? And without question, one of the biggest changes has been the mindset in leadership in healthcare policy about the incredible importance of population health as one of the key drivers in our policy-making decisions. To get healthcare decisions up from individual encounters and think about what we're doing to enhance the totality of health in this country. And commensurate with that is the understanding of disparities and why they are important to driving policy. And, I was with Secretary Azar in Indiana a couple of weeks ago, and we were having that conversation. We were in Indianapolis to talk about the president's HIV/AIDS initiative, which is an incredibly exciting project that we're all very honored to be working on. But in Indianapolis, and we were talking with a room full of stakeholders, and our particular interest and our focus within the HIV/AIDS initiative is on attacking the disparities in HIV/AIDS. And when you look today at new infections, new reported infections, they are disproportionately hitting communities of color. They are disproportionately hitting the homeless population. And unless we unlock that, and unless we can unpack those issues that are affecting that, We are not going to end HIV/AIDS in this country. So it is an absolute requirement that we take a hard look at using the data that we have and look at how we can attack public health issues in a very different way. So a few of the things that we're doing, obviously, one of our biggest roles in terms of nutrition is data. Because one of the things that HHS does, obviously better than anybody, because we're a national agency, is aggregating data. And whether you're talking about nutrition, you're talking about nutrition's impact on chronic disease, you're talking about obesity, talking about diabetes. And obviously we see this in things like the HIV/AIDS epidemic and in opioids, and our huge work that we're doing on opioids. If you don't have the data, you are not going to get it right. We're talking about 320 plus million people in this country. If you don't have real data, you're going to misuse your resources, and you're going to waste money, you're going to waste time, and it's going to cost people lives. So one of the things that HHS does very well is aggregating data that helps us inform policy-making decisions. And obviously CDC is the forefront on that, and I'm sure a lot of you are very familiar and work on a constant basis with the data that CDC puts out. But I want to talk a little bit about some of the more specific programmatic elements. You know, the Early Child Care Education and Obesity Prevention Program, it's a funding program, training and technical assistance. And technical assistance sometimes is a little bit ambiguous, but a lot of times it can be the key to success. We've got a tremendous amount of knowledge at HHS, and it is there for your use. It is there to be put at your disposal to build better programs and implement programs more efficiently. But obviously looking at ways that we can work with organizations to attack childhood obesity and to work with states on developing best practices. And within that program, there's also a commitment to funding research at land-grant universities, which is particularly important here in the Midwest, that looks at obesity in high incidence counties. We have counties in the Midwest that have adult obesity rates in the high 40s. I mean, that's just completely unacceptable. But if we don't research and understand what the reasons are and get the data behind it, we're not going to be able to attack it efficiently. Our community economic development grants, fantastic program, and some folks were talking about this earlier, and I know Mr. Davis is particularly interested in this, and that's the food desert issue. And this is an economic program that HHS utilizes to invest and support farmers markets and investment in retail grocers in what are commonly referred to as food deserts. And this is a huge issue. It's a huge issue not just in metro areas. It's also a very big issue, ironically enough, in rural areas. The places where the food is coming from, the places where the food starts out very fresh. Oftentimes there are not sufficient retail outlets in a lot of those communities to serve the public. And it is just mind-boggling that people can live within a few feet of hundreds upon hundreds of acres of fresh produce, and yet they don't have a close-by retail outlet where they can go and purchase it. So, that's another program that is really important. CDC's Division of Nutrition, Physical Activity, and Obesity Response Programs, and I got to look at my notes because, believe me, the acronyms, you would go crazy. When I worked up on the Hill where I first met Mr. Davis and Richard, I worked for a member of Congress who was on the Armed Services Committee, and I thought the Pentagon had acronyms. They had an acronym for everything until I got to HHS, and I realized that TWA, TLA. You know what a TLA is? TLA is the acronym for three-letter acronym. I just learned that one the other day. I loved it. It was fantastic. So we're going to start using that in all of our memos. But the Division of Nutrition, Physical Activity, and Obesity Response at CDC, absolutely outstanding. Their data is really the cornerstone of so much in terms of programmatic outreach on nutrition and attacking obesity. And a couple of the things that they're doing specifically, one is they're working with states to set standards for nutrition in the workplace, starting with state government facilities and vendors, but it is really working to develop nutritional awareness in the workplace. And I'm not telling people who don't know this, where's the place you eat the worst? At work. You eat something out of a bag, you go and get a donut. I mean, we're over on Michigan Avenue and we've got this huge concourse, this food court, and every day I'm struggling to walk by Dunkin' Donuts and McDonald's and go get my salad because it's so easy, it's right there. But you know, CDC is working on how do we get employers engaged in better nutrition in the workplace. And another great program that the CDC has through that program, they have funded over 3,500 salad bars in schools around the country. That sounds like a lot, it's not nearly enough. But learning how to do it right and learning how to do it more and learning how it's going to have positive impact is the pathway to expanding and scaling out a program like that. And that's something that's very, very exciting. In the Administration for Children and Families, the Head Start nutrition programs are critically important. They're really setting a lot of the standards for childhood nutrition in care settings. And they've also got the Child Care and Development Fund, the Child and Adult Care Food Program, which has sort of the same element that you have in daycare for children, that you have in elder care, also a growing service that a lot of places we're seeing provided. And so if we're worried about nutrition for young people in child care situations, we obviously want to bring that to elder care facilities as well. What we're really trying to do is, starting with this understanding, is to create the body of data and the body of knowledge from which we can base better policies. Because as I said before, one of the things that's so important today in healthcare policy is that your proposals be data-driven. The data is there. We need to use all of these gobs of data that we have everywhere, and we need to be able to look at it, to be able to massage it, as people like to say, to inform our decisions. We cannot leave data on the table. We've got to use it to enhance our understanding and our knowledge and to point us in effective directions. The bottom line is that data holds the key to our future. But when it comes to healthcare, particularly when it comes to nutrition, all of our success has to be community-based. Because unlike a lot of what we're doing when we talk about e-commerce and we talk about information, you can get information from anywhere on the globe now. I can get stuff from anywhere on the globe now. I can get some shoes from Mongolia delivered to my house tomorrow. But your healthcare and your nutrition are two things that inextricably have to be physically where you are. I can't go see a doctor in Mongolia. Frankly, there's not a lot of chance I'm going to go see a doctor in Wheaton. It needs to be local. And by basing healthcare in our communities, we're also able to factor in unique community elements. Because healthcare in Englewood is not going to be the same as healthcare in Crystal Lake. We have different populations, we have different community infrastructure, we have different needs. And we have to factor those needs into what we're doing in those individual communities. So as we move forward and we look at how we can drive overarching national policy, we at HHS are committed to ensuring that local needs, that community needs, are an inextricable part of how we're developing policy. Our solutions have to be community-driven, they have to be scalable, they have to be sensitive to the needs of communities, they have to factor in social determinants and disparities. And one thing one little data point. It's not really a data point, it's more anecdotal. But sitting with our leadership, I've heard this on so many occasions, is articulating the idea that when we talk about improving population health, that when it comes to coordinating care, is that what we want to do at a national level is devolve the decision making to as local a level as possible, so that people in communities can decide what are the best ways to achieve outcomes. And that if we say to a community organization, we say to a University of Illinois hospital system or a Mount Sinai or another hospital system, you know what works in your community. And when you look at the data and you see that better nutrition, that better housing opportunities, that other social support mechanisms in your community will help you achieve better outcomes, use them. We need to get out of the way and stop trying to be the national healthcare police. And we have to empower local citizens, local organizations, and patients to find the best way to achieve those outcomes. One of the things I can tell all of you is that we are very, very interested in working with stakeholders from less traditional areas of health, of population health. And as we know, our traditional obsession is with, the hospital and it's the doctors who cause most of the problem. No, I kid. But we want to ensure that we are listening, hearing about ways that we can integrate all aspects of public health into our policy making decisions. So one of the things that I do want to mention in closing, and I'll take a couple questions if there are any, but here at Region 5 in our office, we have about 500 folks here, outstanding career experts in various areas of healthcare and public health. And we're there to partner with stakeholders, with organizations here in the community to provide most particularly that technical assistance. And that can be helping navigate existing programs, looking at grant opportunities, and ways that we can collaborate with community organizations, educational entities, and other and healthcare providers throughout the region in finding ways that we can best implement our programs so that they have the most beneficial impact on communities. And one of the most important things that we get from that is your knowledge, because we can't build good policies without the knowledge of people who are working in communities all around the country to enhance public health outcomes for everybody in America. So with that, I will take a couple of questions if anybody has any, but please know that our door is open right down on Michigan Avenue, and we'll be happy to sit down and talk further with anybody. So thank you very much.
Questions?
Yes.
What do you feel, if there's anything that HHS can do either on its own or in relationship with other departments such as the USDA to address the input of nutrition, specifically oil and sugar that we're trying to get people to eat less of, but we grow so much of in this country? And how do we change that model so that the Dunkin' Donuts is actually offering you, I don't know, a broccoli souffle? Because there's so much broccoli we have to put into stuff. What can HHS do to address that?
HHS can do a lot. It doesn't help when we had a president who hated broccoli. Remember that? That wasn't a good. That was bad PR. But I will tell you this, and I think that right now one thing that is really, really welcome in this HHS and in this administration is that a lot of the in good ways and other ways, a lot of the old ways of doing business are turned on their head, and a lot of the traditional sort of alignments in healthcare are not as clear anymore. And so, there have been a lot of vested interests who have had a disproportionate amount of impact on our healthcare policy in this country. And I look particularly, a great example is pharma. And right now, as I said, I was with the secretary a couple of weeks ago, and here's a guy who is a pharma executive who is being sued not only by dozens of pharma companies for regulations that they think are unfair, but he's being sued by the company he used to be president of. That tells me that we're onto something. And it really tells me that we're not looking at just the sacred cows and the old traditional alignments in healthcare. So when you talk about, obviously there's a lot of, as we like to say, rent seeking at HHS. There are a lot of people who have a lot riding on the regulations and the policy decisions that we make. And, a lot of people in the processed food business spend a lot of money to try to influence those policies. I will tell you, after 30 years in government, it is very, very refreshing to be at a department where a lot of those dollars are very, very poorly spent and in fact wasted. Because now so much more of what we're doing is driven by the data, is driven by our professional staff, our career staff, and driven by evidence. And that is a refreshing thing to see in government. Anything? Yes.
So that was a great segue. Thank you very much for your presentation. I had a question. You talked about the career staff, and obviously those people stay from year to year to year to year.
To year to year to year to year to year.
Since you were in a political appointment, and I actually went to high school with the person who was your predecessor under the other administration.
Which one? Kathleen? Okay. Yeah.
And she's amazing, as I'm sure you are. But I would just love to know how you.
Not as amazing as her.
The political aspects of your job, not just from Kathy to you, but from other people before you, because obviously administration policies change. And how does that impact the overall part of HHS that you're overseeing?
I'd be lying if I said there doesn't continue to be sort of a separation between career political appointees, and then we also have the commissioned corps, public health service, so that there are some sort of groupings of folks. But I will tell you that, again, one of the great things about coming back in with a team of people who have experience at HHS is there's none of this sort of skepticism or arm's length relationship. We've all worked with the career staff before. I learned 12 years ago how incredibly smart, committed, and outstanding the career staff are. Now, it's like all of our organizations, whether you work at, Amazon or you work at a mom and pop store, you got good people and bad people, you got hard workers and less hard workers, but by and large, the knowledge base, the commitment to mission among our career staff, absolutely unquestioned. I rely on them every single day to better understand policy, to better understand programs. And the God's honest truth is there is so much commonality in our mission that there really it is almost impossible to find areas of divergence. Because when it comes to our shared commitment to mission, it's really exciting, and it's really great because we can sort of work off each other and feed off each other to work to achieve our common objectives. Yes, Jeannie.
Thank you. So this is kind of a segue from what Mary was saying, because when you think about the change that happens, there's also that level of continuity that comes with career staff. I feel like there's a sense from people sometimes that they don't have a voice in the programs and policies that happen in agencies like HHS. And we spend a lot of time writing comments and answering the questions that are put forth. Well, what do you think about a program? Is it important? And how should it be changed? How can we improve nutrition? But I'm not sure that people recognize the role that the public can play in the voice of the decisions that's made by your agency, and so I just wondered if you could touch on that slightly.
Yeah, and that's a great question. It's counterintuitive to think that any organization like in the federal government itself, but HHS, which is 80,000 people spending $1.3 trillion a year, pays attention to anything. But I will tell you, I'm not saying it's completely different. It's enhanced in this administration. When we talk about rulemaking and public comment, that's real. And I know you think that, oh, it's just going into some, it's like the suggestion box at work. There's actually a little mini shredder in there, and it just goes in there. We take that stuff seriously. It is not just checking a box because the law says you have to take public comment. Every single public comment is read and reviewed and factored into the rulemaking process. Now, that doesn't mean that we necessarily have to agree with every comment or integrate every suggestion into a rule, but every single one of them is read, and every single one of them is analyzed and becomes part of the entire analysis of public comment that goes into the rulemaking process. And one thing I will say, and Greg Ross, who's here from my office, one of the outstanding career staff, and he's a big part of this in my office here, is our commitment to things exactly like this. Through the regional offices, and in fact through the Secretary's office in DC, is being, as we say, out there. We have to be out there in the regional offices. We have to be hearing and listening and interfacing with stakeholders. But the Secretary's doing this in DC too. And I kind of make light of it because, what's the Secretary doing this week? Is it the roundtable on toe fungus? Because on a weekly basis, he's bringing in experts from around the country to talk about key public health issues. And a lot of you probably saw our kidney initiative, changing kidney care fundamentally for the first time ever. And that came out of learning that the Secretary and the Deputy Secretary especially got being out talking to clinicians. Because I'll never forget the Deputy Secretary after a meeting saying, it's amazing when some of these experts told me that if you were a cancer patient 50 years ago and you went through a time warp and you woke up today, it's a whole new world. First off, you'd be alive, probably, which you wouldn't be 50 years ago. But the difference in cancer care from 50 years ago is mind-boggling. And the success rates are astounding. But if you're a kidney patient, it's the same. And as somebody said, the pictures on the wall of the dialysis unit are the same that they were 50 years ago. It's that bad. But what we realized was that the way we reimburse for kidney care had created perverse incentives to maintain the status quo. Our policies weren't driven towards improving outcomes and helping patients. It was keeping the status quo because a lot of people had figured out a way. You get in your lane, and we're spending $38 billion a year just through Medicare and Medicaid on dialysis. So there are a lot of people who had a vested interest in the status quo. But we've turned that around, and that's from public input. And that's why having these dialogues and these discussions are very important. I'll give you one more anecdotal piece of evidence. And this involved me in this region. But earlier this year, actually in January, I was in both Ohio and Indiana early in the year. And both instances, I was particularly there for events with their state opioid task forces. And within a week, I had talked to the drug czar, the sort of the general term, every state has one too, and whoever the senior person is who's working on the drug abuse, addiction, illicit drug issues. I talked to the drug czars in Ohio and in Indiana, and both of them took me aside and said, I got to talk to you about meth. It's huge. It's a huge problem. And here in Chicago, we haven't seen it yet, but it's coming. And, I talk to the DEA on a regular basis, but talking to the folks in Indiana and Ohio, where the opioid epidemic had hit early and the response was earlier, and so the transition now we're seeing in those states to meth. And the problem was we've provided all these resources for the opioid epidemic and legislation. By the way, Mr. Davis and Congresswoman, when we put that language in the bills and we have all this great funding, bipartisan funding from Congress to attack the opioid epidemic, unintended consequences, And then meth starts to spike in these communities. And the problem is all the funding that we're providing them says specifically these are for opioid initiatives. That means you can't spend it to combat meth because it's not an opioid. So what we were able to do very, very quickly, instead of waiting for data to come up from public health agencies and coroners to the state, to the CDC, and then be in a quarterly analyzed report that goes to a report to the secretary, we're able to get in real time.
To the first floor. To the first floor.
I'll be right there. But, you know, we were able to talk to the secretary right away and say, this is a problem. We've got to start getting our people out into the communities and seeing how extensive this is, how big an issue this is, where it is, and what we can do about it. So at the same time we were talking to our stakeholders in states, our partners in law enforcement and first responders to find out where are we seeing these spikes in meth. We had lawyers in DC working on trying to figure out ways that we could free up some of that funding and give some more programmatic latitude to states to use the existing funding to be able to attack this right on the front lines. So again, what we're doing in rooms like this, my colleagues in the other regions, what they're doing in the Secretary's office has a real impact on our policy, and it's one of the things I'm most proud of working in this administration. So, anything else? Thank you all very, very much. I appreciate it.
I'll reach out to you, Doug. Thank you so much. Commissioner Boykin, please, some words.
We'll give another round of applause for, I want to call him Secretary Doug OBrien, but I'll call him my friend. Doug OBrien's doing tremendous work.
I'm proud to have that label from you.
All right, thank you so much. Thank you for all your help. I want to bring up the next person, Dr. Willie Wilson. I know we have Congresswoman Robin Kelly here. She's going to speak right after Dr. Willie Wilson, but I want to bring up Dr. Willie Wilson. For those of you who don't know him, he is a philanthropist. He is a businessman par excellence. He hails from Louisiana, and he ran in this most recent election for mayor and won 14 of the 18 black wards in the city of Chicago. And so he really understands how to reach the community, how to reach African Americans. And because a lot of what we've heard today is really all about figuring out ways to reduce obesity, figuring out ways to help get better nutrition outcomes for African Americans and for Latinos and others, so that we can make our city stronger, make our county stronger, and make our state even stronger. And so Dr. Willie Wilson really has the prescription to do it. I think he understands how to reach the community. And I wonder if you'll put your hands together for Dr. Willie Wilson. Thanks.
Let me thank Commissioner Boykin and all the other who helped make this possible today. My good friend Congressman Danny Davis and all the other officers here, and Congressman Kelly, the ministers, and all the other staff and from this particular city of Chicago and this department. I want to give you a perspective from strictly this is my perspective. I think that in order to talk about nutrition to particularly the black and brown community, first they have to understand the meaning of nutrition. Sometimes you can go to school and you can read about it, but it still doesn't sink into you what it's all about, right? We need to invest in resources as well. There's not many places in terms of nutrition within particularly the black and brown community. If this place is right here, for example, Wood and Roosevelt, but there are people who maybe 10 or 15 blocks from here don't even have the money to catch a bus to get down here, right? So you have to kind of understand all of this. If the variance is not in place and they're being blocked for whatever reason, it's impossible that we could make sure people understand it. Health is very important. I didn't really understand the word nutrition myself until I got up to a certain age. But I found out that after I got sick. I am a survivor of prostate cancer. I'm a survivor of a major heart attack. So I can relate to nutrition, not about something that I read about. But if it had not been for the blessing of the Lord to have a business, I wouldn't have been able to have the money to get the help that is needed. Now, after I got sick and got involved, well, the doctor said I eat too much fat, you know. Didn't have the right nutrition. I got my cholesterol too high, all right? And it's the same that work today. We do a lot into the community trying to help as related to people having their food to eat. I think last week we was out in the senior citizen home, and we supported last week each senior citizen. We just given these gift cards with $20 a piece to buy food. In case you didn't know it, the average senior citizen in Chicago, especially in the poor community, they live off less than $3 a week for food, right? And that's something that you may not even know about it. How I know about it, I'm out there every day in the field helping. So they living off $3 a week for food, that's $12 a month. When I give extra $20, that means it's up to $30-some a month. How can you understand nutrition when you don't have the money to buy it in the first place, right? I think you got to take a look at it and say that all people is important. It affect everybody. I'm sure the budget of y'all that you have here and also nationwide is in the billions of dollars. But how did that reflect to the poor community? You know, if it's reaching back to the poor community, if you're really getting out there. So people ask me, they say, well, we was giving away these dollars into the black community a year or two ago. Well, we was giving away, I think I must have gave away that day about a couple $100,000 to people, just cash. So people would ask, why are you giving cash away when you should buy a person a turkey for Thanksgiving? And I say, how can we buy people turkey for Thanksgiving when they don't even have a stove to cook it on? Okay, the mind, you know, don't even understand what's going on. You know, I say we have to make the investment back. After all, the taxpayer dollars should reflect its population. You know, we need to look at it that if you're trying to reach the community, well, first look at your staff that you got working for you. How many black and brown people you have there? How many is in different positions? Okay, where are they from? If they from the community, or they from Highland Park or Oak Brook or some of these other areas, you must reflect it. Then once you hire people out there that happen to be African American in particular, you got to make sure they have the position and the freedom to really give you the right input, you know. But you also have to have people in those certain positions that reflect the makeup. If I'm an employee of yours, I'm afraid to say we need X amount of dollars here because I might get fired if I say the wrong thing, all right? All African American people that happen to be black is not black inside because they're not exactly from the community. In other words, it doesn't match up, you know, right? So people can talk certain conversation, but when they talk certain conversation out here, unless you're really talking black or you're talking brown, but you're in an environment that you're uncomfortable to tell the truth because you got to survive and you got to take care of your family, you know? That had to come from that perspective, you know? How do I know? I'm a poor, and honest to tell you that I only gotten a 7th grade education and never been back to school, but I learned the hard way. And then, so when I found out about nutrition, it was because I got sick and I happened to have a business that could afford me the opportunity to get to a doctor and find out what this is about. And then even after I found out what it's about, and after being talked to, I still had to go and try to still make sense out of it, all right? And so in certain communities, they didn't get that opportunity, so they continue to die. I mean, literally to die. You know, can't get the doctor, you got problem, family can't get the kids, they go to bed at night hungry, you know. So if you're going to bed at night hungry, trying to get a bus, trying to get to work, how can you ever think about nutrition? If you ain't got the money, how can you think about nutrition? You know, these are real facts. You know, we all have to take a look at ourselves and say, are we doing the right thing as related to the society in which we represent, not just our little corner of the world, but all of the dollars in all of the community, which it should reflect. You know, it's okay to go home if you have a good paycheck. Talk to your kids about nutrition. It's okay to do that. But in Chicago, a lot of people my color don't even have a home. And if they have a kid, don't even have the resources to take care of those kids, to even buy food unless they don't talk about nutrition. You know, my suggestion is to take some of your budget, reflect the community, build some of the health centers like right here within the Inglewood, the Lawndale, the Austin area. Talk to the leadership of the pastors, the ministers, and things like that, the different organizations, hold them accountable. So when you go home at night, and when you take these dollars, wherever you live at, you can be proud to say that you did your best at the end of the day to reflect all citizens of Chicago and the fellow dollars and things of that nature, wherever you may be found that you did a good job in that respect, that you made the extra effort to reach out. It should reflect the makeup, people dying. You know, this whole situation is very, very serious. You know, I ask you to take a look at that, expand, take and reach out more than just words. You know, go out there. If you're afraid to go out there, look up myself. I'll take a group of y'all all in the black neighborhood, all right? And everything. And we'll make sure you're okay, all right? And get a group of ministers to dig into the problem and let's straighten out the problem, you know, because again, people is dying. And I want to thank again Commissioner Morgan for allowing me this opportunity, the rest of you all, and allowing me the opportunity to talk. When I talk, I just tell the truth because I don't know no better, okay? All right? And so I speak from the heart, so therefore you speak from the heart, you know, it's always reaches the heart, you know, and so I just said, it doesn't mean any kind of way of offending anybody or putting anybody down, but if you don't tell the truth, it can't reach you know. If you play politics, then somebody gonna go over somebody's head. Just tell the truth and cut out all politics and all other things, you know? Again, thank you very much.
Come up again. Thank you, Doctor. Our next distinguished speaker is Congresswoman Robin Kelly, who's been also a big champion for the FQHC and funding for our mission and vision. But please, Congresswoman, please take the podium. Thank you so much.
Thank you so much, and it's an honor to be with you today. Let me begin by thanking Richard Boykin and the Academy of Nutrition and Dietetics and UI Health Miles Square Health Center for organizing this important summit. I've never been here before. It is really, really beautiful. I would be remiss if I did not thank my colleague and acknowledge Congressman Danny Davis for his leadership in making this summit a success and his tireless effort in the House. And I will say that he always brags that he has the most and the best health care in his district. So we're all jealous of him. But good to see you, Danny. Good to see you, Dr. Wilson. I could not be more excited to be here today in my role as the Congressional Black Caucus Health Brain Trust Chair. For those of you unfamiliar with the Brain Trust, it's the foremost authority in Congress on health disparities impacting the African American community and all communities of color. It came into existence during the earliest days of the CBC under the venerable Congressman Lou Stokes. It would eventually grow into a chair role under my predecessor, Congresswoman and Dr. Donna Christensen of the Virgin Islands. CBC Chair Marcia Fudge was the chair at the time at the end of my first session in Congress, and she told me I will be the next chair. And when Congressman Fudge tells you you will be, you will be. So the work of the CBC Health Brain Trust is focused on decreasing healthcare disparities, improving healthcare access, strengthening the diversity pipeline, because there's been many studies, you do better when it's someone that looks like you telling you you need to do better, and achieving health equity in a generation. While our primary focus remains the African American community, we know that we're all in this together. When one community is uplifted and empowered, all communities benefit. So the CBC works in close conjunction with the Congressional Hispanic Caucus, the Congressional Asian and Pacific American Caucus, and their respective brain trusts to advance comprehensive health equity legislation. As a coalition, our major effort is passing the Health Equity and Accountability Act, also known as HIA. In early 2020, my KPAC colleagues will be reintroducing it. This bill can be summed up in one word: comprehensive. So each Congress, we take turns introducing the bill, and it's slowly being absorbed in our healthcare system. Some things are in the Affordable Care Act, some things we have not been able to achieve yet. That's why we keep introducing it every Congress. As I say, it can be summed up in one word: comprehensive. I know that's a term tossed around a lot these days, but this bill truly is. It seeks to address immediate health inequities and disparities by reinvesting in communities and focusing on community-centric care, something I think Dr. Wilson was trying to say. It also looks at the long term and works to create a pipeline of medical, biomedical, and practitioners that look like and come from the communities they serve. When you consider the need, the only solution to achieving health equity within a generation is an aggressive and comprehensive bill that builds on the success while addressing the shortcomings of the Affordable Care Act. And HIA does just that. We need this bill now more than ever. Of the top 10 killers of Americans, African Americans die from 8 of 10 diseases at disproportionately higher rates. Many of these diseases and disorders are directly related to your work at the Academy, namely heart disease, stroke, diabetes, kidney disease, and cancer. Each one of these diseases intersects with obesity, poor nutrition, and poor dietary habits. If we can address the underlying contributing issues, we can reduce the number of people dying from these diseases. Another area where this intersection of obesity and mortality is growing is maternal mortality. Compared to 1985, the number of American moms dying from pregnancy or birth-related complications has doubled. Each year, we lose 700 to 900 American moms, and an estimated 50% of these deaths are preventable. About 100 of the moms who will die are from Illinois, and our preventable death rate is closer to 75%. And while all women are affected by this, African American women die 3 to 4 times the rate of white women, and in Illinois is 6 times the rate. If you go to the state of Washington, Native American women die 8 times the rate of white women. It is clear that we need to act. All moms deserve the chance to be moms. So I deeply appreciate the Academy for their support on this issue. A few months ago, you hosted me for a conversation about the intersections of nutrition, obesity, and maternal mortality. That conversation and ones like it have a major and positive impact. They help us understand all the facts so we can craft better policies that save lives. So thank you. You consistently and rightfully focus on how diet and nutrition play a key role in our lives and nutrition. And I do have a bill, the MAMA Act, that many organizations are supporting to try to see what we can do about maternal mortality and morbidity. And I'm hoping through Energy and Commerce, even though Ways and Means already had a hearing about it, that we can get this bill passed. In many ways, it's a classic case also of we are what we eat. If we eat unhealthy things because the only store with food in our neighborhood is a 7-Eleven, then our bodies will be unhealthy too. And that's why I'm working with Congressman Mike Boss, a Republican from Southern Illinois, to pass my Farm Flex bill. This bill, previously endorsed by the Urban League and the Farm Bureau, interesting combination, would help farmers grow more healthy fruits and vegetables for our community without losing crop insurance coverage. My district is truly urban, suburban, and rural. It starts around the Museum of Science and Industry and goes 100 miles south, including 1,200 farms. It's a tragedy that some of my constituents live less than 20 miles from farm fields but can't get the healthy produce that they grow. Right now, the rule actually hurts farmers who want to grow more fruits and vegetables, even if they donate the yield. My bill, which has been called a win-win by nearly everyone, would address this and help our farmers feed their neighbors in need. We had hoped to add it to the most recent farm bill during the last Congress, but alas, we're now working to pass it as a standalone bill in this Congress, and as always, we need your help. I hope this gives you an overview of the CBC Health Brain Trust and my work in Congress. As I've said before, if you're working on something that my team and I should know about, please, please, please call or email. We want to know. We work on a lot of different things, but you're laser focused on your work. So if there's something coming down the pike that you don't like, we want to hear about it sooner than later. But we also want to hear about if you really like things too. We don't hear about that enough. No one has a monopoly on good ideas. We certainly don't. And it's going to take all of us working together to end inequality of our healthcare system. So thank you again. Thanks for inviting me. I'm so happy to be here. And if you have any questions, I can answer. I hope I can answer. I'll refer to Danny.
We can have our panel discussion, but let's have you just stand at the podium. We'll bring up Dr. Wilson also, please, for any Q&A from the audience. Open discussion. It's fantastic at this juncture. Please, sir.
The congressman will answer all the hard questions for me.
Thank you so much. I'm Sharon McCauley from the Academy, and thank you for being here. I just want to piggyback off on what both of you have so eloquently talked about and what Doug from HHS was stating about the data-driven and that aggregate data and the wonderful words from our representative here that we talked about coming up from the ground up. So at the community level and that data and those wonderful projects that you've all talked about, are you able to collect that data then to drive that back up for the policies that need to be handled?
Are you saying the data
From any of the community programs you're working and the local items that the projects that many of the regional directors in HHS monitor, and they're always making sure that they look at the measurements so that way we can manage what we measure. So I was just wondering, with that type of data, is there any from your community programs, is that anything that you're able to grab upon to assist with any of that policies that we're trying to drive for your legislation?
We actually, I wrote when I came in, or after I came in, the Keller report on healthcare. So we have a lot of data there and things that can be done. And with all the programs we have, we keep track of everything and what people, anecdotal, what people have said. I just had a maternal mortality hearing at Advocate Christ on Tuesday, and we had witnesses that were doctors and social service agencies, and actually had a survivor who gave birth and speaking. But we keep track of everything, and that is kind of what informs our policy because of the data.
So it is working, but what we're trying to accomplish is trying to demonstrate and then document and then collect that aggregated data and push those policies.
Well, I was going to say that, as far as I'm concerned, I don't have any data personally, because the neighborhood in which we go out into is so, you got to figure that. If I go to Lawndale, Inglewood, you got to figure 50 to 75, 80% of those people need help. It's kind of like, I don't look at data when I go in a place, I know everybody's hungry, so I just start giving them food, So, personally, I don't have it. I think that the need is so great. I'd say let's do something to help. After we begin to help, then let's turn around and look at the data afterward. That's kind of the way I operate.
But I do think because of the work you do, you know, that's people do look at what you do and what you have to do, and that's where we get our information from. Even if you don't keep it, we're looking. You know, we know, you know, what you do, and what the needs are. And actually, there was I know her first name was Maura. I can't remember her second name, but she did a thing on, you know, food deserts and. You know, we talk about nutrition, but people can't even, I think what she said, they could get a cheeseburger before they could get an apple. And I know statewide, you know, we think it's an urban problem, but it's a suburban problem and a rural problem too, that when I worked downstate, you know, they went to the gas station to get a banana, you know, because they live so far apart.
Let me add to it too is that, look, I understand data. I'm a business person.
It's just that HHS is driving so much of that, that's why. I'm just trying to grasp it.
Go ahead.
But I think much of the evidence-based concept, I mean, many people now are using evidence-based, show me it works, or bring me something that has been proven.
That's right.
And certainly funding now, much of it is based on evidence. Show me that this is going to work. There are a lot of people who seem to think politicians sometimes can work magic. And you know, they'll say, support this program, or I'm trying to get this grant. Call them up and tell me to give it to them. And you know, you gotta explain, well, it don't quite work that way. You know, I sometimes will just tell people, look, I used to review proposals for so and so, and we don't always know where they came from. They'll take all the information out so that you can't even determine what city. And that's to try to make sure that what we heard earlier, that these things work, that you're saying you can do, and you're not just getting some money to do nothing. Yeah.
Thank you.
Thank you very much. I want to appreciate both of you all for your presentations. I thought they were outstanding. Let me say this, much of my frustration is that these health disparities that we hear about in terms of African Americans, it seems like since the Moynihan report on the family, black family, there hasn't been much improvement. In fact, we've had some slippage. And so how then do we actually reach those folks that we're talking about? I mean, I know that the Academy wants to do something with fraternities and sororities. I know we want to do something with the faith-based group. And so maybe with your leadership, maybe we can bring those groups together, fraternities, sororities, and for the faith-based community, and really figure out a way to dig into this and try to change the narrative and save lives in the process. What do you think?
I think that's all good, but I also want to remind people this here as well, is that if you can count how many people live in a neighborhood in terms of population-wise, if there's 100 nutrition centers in Chicago, and there's only one in a black and brown neighborhood, just using that for an example, then you know there ought to be some more out there, put out there somewhere. But we also got to take an approach that we can count the people who get murdered and shot and killed on a weeknight. Why can't we flip it around the same way?
Well, you know, that's my passion, the gun violence. But also, I know that I've talked to you guys about, you know, what can we do because of the obesity in this country, and it seems like it's younger and younger and younger, and some of it is because they can get a cheeseburger before they can get an apple, or people don't, and I'm going to use my stepdaughter as an example, even with my grandson. When I see some of the stuff, because she's working and busy and all of that he eats, I'm like, oh my God, even though he's skinny as a rail because he's picky, but that like education needs to come with this. When I was in school many moons ago, I remember having was a home ec, and we talked about food and nutrition, and they don't have any of that now, and that was in public school, that we learned some of the stuff. But I think some things are generational, and we just need, or tradition or cultural, and we need to have healthier eating, but also access to nutritionists, and just like any health access. And then also, again, we need to diversify the pipeline too. I think that would help. And then have, as Dr. Wilson said, more facilities in the areas that they're really needed.
What can we do to sort of scale up these kind of conversations, have these conversations around nutrition with the Health Brain Trust, to expand nutrition, put on the front burner of the work that you're doing?
Well, we put on health forums all around the country on different topics. It just depends where I am. Like, I've done AIDS in LA and San Francisco, and so I've done infant and maternal mortality in Memphis. So I'm ready when you are, to, and even in DC. In DC, we can put on something there for people. I'm also the chair of the Caucus on Black Women and Girls, and that's where I ran from today, because we had a forum today. But we talk about health, wealth, self-esteem, and all of that good stuff. So no, we're always ready, because this is something really near and dear, to my heart. This topic.
I think coming off, that's a great point, and thank you very much for making that. I think some of what you said is probably related to what people choose to eat, can be related to self-image or depression or concern about lifestyle, or, that's common across everyone, not necessarily Black and brown people. But I think working with the women and girls group that you're talking about, we could incorporate, whether it's financial management or nutrition or sexual health or whatever. It seems like that maybe you're already doing those things, but that would be a great forum for.
But we do stuff, we repeat things, and we do them all around the country. And here, of course, my partners are Yvette Clark from New York and Bonnie Watson Coleman from New Jersey. So we do stuff all over about all kind of things. So we don't care about repeating.
I also think that you have to add to that. And look, I think all that is good. Go out and meet and hold meetings and everything. The real world from which I come from, different, totally different. We need to go into those communities, get with our churches, get with people on the ground, different organizations out there, establish those, put economic health nutrition centers within the community, and start working from that perspective. We've had thousands of meetings. Nothing got better for what you already have. So why are you gonna keep going down the same road? You can go down that road and continue to add to it, but first make the investment over here and make things happen first, and then we catch up with the rest. Otherwise than that, it's just a exercise, but the real people who really needs it, they're like 10 or 15 blocks down that way. So either way.
And we are in the neighborhood. Like, I just came from Chicago State, so we just don't meet with professionals. We are in. We go to the neighborhoods and send out all through, my district, which is, again, very urban, suburban, and rural, very diverse. My district has the most African Americans in it, more than Congressman Davis and Congressman Rush now, but and a growing Hispanic population.
Certainly from our perspective with Miles Square, we have very unique programs we're starting here. More of a team-based approach with regard to chronic disease management. I think the other issue that's very important for our health centers also is actually putting navigators into the healthcare systems, because here's the reality. Healthcare systems have become so complex to schedule a test, a procedure, a laboratory test of some sort. by embedding navigators within the healthcare centers, we're able to help our patients to navigate a complex system in a very, very simplistic way so they can get the care at the right place, right time.
Can I ask a question? What is the you guys' budget and how much does it reflect the Black and brown community? Your total budget.
So we just went through a budget, but it's, I mean, several millions of dollars, but clearly our FQHCs are embedded in the most at-risk communities in addition to our school-based also. So we're hitting the kids early in elementary school, high school, et cetera. We're actually in the CPS schools. And more importantly is these centers are not only for the students, but for the community as well. So
Yeah.
anybody can come there
I agree.
and get proper care.
I work with the Chicago Partnership for Health Promotion, and we're focusing on every single one of those school-based call centers is like a spoken wheel. And so in our organization, we work in churches, pantries, the corner store, everywhere that's close to that school-based health center. And I've been at Iman, Light of the Night, where there was a block party where there was a shooting. And so people came from the community. There was a grandmother, there was children, there was, somebody was doing a demo on a healthy wrap. People were making like kale smoothies. So it's not just being out in the community, but you have to be able to try to teach the community all these different type of healthy recipes, and it's not just being at the health center, but it's also being at the church or being at the corner store. And I've been where, I will see the children in the school, but then they're coming to the corner store to get something to eat, and you see them at the school, and then you also see them at the corner store. So it has to be the whole community.
Are you talking about Iman in the 60s?
No, the Iman that I work with right now, there's an Iman, not in the 60s, it's now. It's called
No, I go to a place in the 60s, the number street.
Oh, so I thought you meant in time. I was like,
Yeah, that we work with. And they are definitely in the community. They come outside their doors, and we've partnered with them, from time to time. But also there's a program, and I cannot remember the name, where, and they were just in my office, where they give folks like $1,000 to $2,500 or $3,000, depending. I can't think of the name of the program, because they feel that people know what they need better than I know what they need, and it's gone really well. People have not abused it. They've used it, for different ways. Like one person used the money and he got himself a lawnmower, and then that's how he mowed lawns. And then in the winter he made enough money, and with that money he bought himself a snowblower. And just because there's so many people right on the edge, but it's an excellent program, but I just can't think of the name of it, where they help people, in that way. And sometimes, they do use it for just to help with groceries. They don't use it all at once, but just a little bit, because the healthier food is more expensive.
You ask me questions?
Yes.
Sir.
I have a question. My question is, do you guys have someone that you can make accountable for the investment that is needed, is invested where it needs to be invested, and then someone to check on them to make sure they're doing what they're supposed to do?
So with Miles Square Health Center, we are accountable to HRSA, and we often will have status reports, and then we must validate what we're doing. So so there's that check and balance that we must maintain. In fact, we were working our current metrics for our diabetes programs here, and we're going to submit our first quarterly report to HRSA with regard to what our action items are doing and how we can best serve our population. So we are not just given a blank check for various grants and federal funding, but we do have to be accountable for what we're doing. It's quite robust.
And you have someone to check on that person to make sure it's school am I supposed to go, right?
Well, so that's Dr. Jasanoff, who oversees the medical aspect of the organization. So it is, for me, fortunately, I come from Advocate Healthcare, where Advocate Healthcare was a leader in clinical integration, population health outcomes, and they've done quite well, and they're nationally known. So I was able to bring that knowledge base here. I also have an FQHC background as well, so I'm able to really bring best practices to the system here. Congressman.
And of course, part of our job is oversight. And I mean, there's so many investigatory, three things we do. We make laws, we appropriate money, and we investigate to make sure that money is being spent the way it was intended to be spent. Of course, sometimes it's not, but there's always somebody looking to find somebody else that's not doing what they're supposed to be doing. I'm saying there are those whose whole function is to do nothing but investigate. But I think the issues that we're really talking about is how do we educate people so that they take advantage of the nutritional understanding that's being put forth in healthcare. Because, for example, obesity. There are people who know that obesity is a problem, but aren't really able to do much about it. And to discuss with somebody their weight and, and suggest that, hey, honey, you ought to be, kind of reducing a little bit or something. That's not really all that easy to do. I'm sometimes in a group where 75% of the people in the group are obese. Seriously, sometimes obese. Well, I ain't gonna say much about that, and say, hey, we ought to be losing some weight if we really want to reduce our illness. I'm saying confronting lifestyle is a big part of healthcare. And that healthcare is much more than the doctors and the clinics and the institutions. But individuals have to take a great deal of responsibility for their health if they want to improve their health status. The doctor just ain't gonna be able to do it for me. If I gotta back up from the table a little bit, or if I gotta find that salt really isn't the thing that's gonna do it for me, I gotta figure out how to make it without as much salt. I gotta make it without as much sugar. And if we don't learn that, then of course we'll still be dying sooner than folks who do. And only somebody benefiting would be the undertaker.
Any last minute comments from the audience? Let's segue into our closing remarks. Thank you so much, Thomas. I can introduce Terry Raymond from the American Academy. Thank you so much.
Thank you. Well, we've heard from some amazing speakers today. Policy leaders, community leaders, health professionals. We've talked about some of the crucial issues in us being able to access nutrition care. We've heard about some positive ways, some challenges. Where do we go next? What's our next step? We know that nutrition, I think I'm preaching to the choir here, nutrition is a cornerstone of our health for all chronic disease states, whether it's heart disease, high blood pressure, cancer, obesity, diet, nutrition, and lifestyle is what is always part of the maintenance. It's part of the program. It's part of what we have to do for people. We know that medical nutrition therapy improves health. We've proved it. Why do people have to wait until they're in the hospital to get it? We need to be out there in the community working with everyone throughout their life. We need to be in prevention. We need to get medical nutrition therapy outside of critical care into everyday care. It's very important, that more than important, that we do this. We can get out into the communities. Right now, there are countless ways to do that. One of the things that the Academy is doing is that we're joining with Black sororities and fraternities and working to increase they're going out in the communities and increasing participation in nutrition, community nutrition programs. Thank you to the wonderful Representative Kelly for that idea. Everybody's and every one of you has ideas. Let's not go out that door and go, oh, that was really a great conference. I really learned some things. I'm feeling good. Let's have some action. Let's look down some avenues. Let's look a little bit differently. Let's get together and work. To heck with silos. They store corn, I think, or something, you know. We need to really get out there and make it happen, okay? So don't just walk out the door and go, that was great. We'll be doing the doctor and everything here and every place that everybody's working in communities a disservice. Let's get together. Let's make plans for the future. Let's work together to make this happen and impact people throughout their lives, not just when they get to critical care. That's my words. Thank you.
We had 4 hours of great discussion. We've had some great content proficient folks here that joined the phenomenal discussion, and something that seems so simple, nutrition, right? I mean, how come we can't get it right? America just celebrated 2 anniversaries. They are 50th anniversaries. We brought a man to the moon and back based upon John Kennedy's wishes and desires, and Woodstock. If we can get a man back to the moon and back and have a great time through Woodstock and live through it. I was a young youth at the time, so I was not there, but I can still embrace the music was there. We can easily figure out how to embrace nutrition in our areas that need it the most. But let's have this again next year with some positive plans of action and move forward. But thank you, everybody. Thank you so much.